If you look at the healthcare industry in India, this is a good news for all of us. Whoever is there in healthcare industry, it need not be just doctors, the owners of the hospitals, paramedical people, pharmacy, lab, anything that is radiology, everything that is related to healthcare industry. The statistics, what do they say? You know, Healthcare is the third largest growth segment in India. That is number one. Number two, if you look at the healthcare industry in India, you see here in the US dollars, from when in 2008 it was 50 billion dollars, it was steeply rising to touch $250 billion by 2020. It is said that you see the rise in the curve. It has been extrapolated that this rise will keep on going until 2050. Maybe after that, it might touch a plateau, which means for the next 30 years, for whoever has been there in the healthcare industry, for them, the industry is booming and growing. COVID has actually proved the same fact, no, for all of us. On top of it, what is happening in our country? There is growing middle class. There is growing and aging of population. Okay, so there is growing of urbanization of people. When you have elderly population, the number is growing. You have more lifestyle diseases, and also pollution is growing right now, which results in more chronic diseases, which results in more organ failures, which needs more ICUs. So it is not just that healthcare is thriving in India. Also, the base feeding of healthcare industry is also growing. Similarly, basic need of ICU services is also growing in the country. Now, this is the current statistics. In 2017, the data shows that the per 1 lakh 100,000 population per country, how many ICU beds are there, critical care beds per 1 lakh population? When United States has 30 plus beds per 1 lakh population, India doesn't have even 3 beds per 1 lakh population. What is the growth of COVID? COVID centers, COVID ICUs have been formed, but temporarily formed by most of the government bodies, right? Even in this 2.3 per 1 lakh ICU beds, 80% are actually in metropolitan cities only. These are total number of beds per 1 lakh population. You know very well, we all know very well, that reasonable ICU beds are there currently available only in metropolitan cities. Maybe in the metros, tier 1, tier 2, maybe tier 3 cities. Beyond that, we all know that, no? At many of the district level hospitals and none of the taluk level hospitals, at least many of the places, you don't have reasonably good ICU beds. That is the data speaks that. As on 2021, last year, India touched 130 plus crore population, where you have 70% of Indians, they reside in rural areas and suburbs of cities. 70% of the specialist doctors, they are only in cities. So what is happening? You have all the critical care uh, requirements, the people who require critical care from the villages, okay? They come to taluk or district hospitals, isn't it? First level is there. And if they are the first line platforms, for treatment. Now, from village, they go to taluk level or district level places. If they don't have proper ICUs, especially in the suburbs, you have to refer to other hospitals, corporate hospitals. If you are in a city suburbs and you don't have ICU, you have to refer the patient to in the city to corporate hospital. Or if you are in a tier 3 town or maybe in a taluk place, you don't have ICU, you have to send the patient to either city or tier 2 city, either to district headquarters or tier 2 city where you have ICU. So that adds, number one, loss of practice for doctors. Number two, adds burden to the patient. That is what is happening. Now, as I told you, we are going to dissect several aspects and then understand why the problem. If you look at the breakup of whole hospital sector, you see you have pharma, you have equipments, you have lab, that is diagnostics, insurance, you have digitalization. These are the part and parcel of whole gamut of healthcare, right? If you take the hospital, your equipments and including beds, cots, everything is one side, and then your lab and pharmacy on the other side. Remaining 70% is about hospitals running the services, healthcare services, which means through manpower. This constitutes doctors, entire manpower, medical, medical and paramedical manpower. So, what is the problem here? You have standardization across these small areas. For example, you take paracetamol. You may call any of the trade name for that. I don't want to take the trade names here. Any trade name, but paracetamol works the same in Kanyakumari, Kashmir, in Gujarat, and Arunachal Pradesh. Everywhere you go, whether you are in a most rural area or the city in the middle of Delhi or Chennai, it works the same. You take monitor, it measures the same everywhere. You take cot, it is the same. You take CT scan, you take MRI, you take ultrasound, echo, everything works the same. Similarly, LFT, it measures the same, no? Whether you take blood test and then send for LFT, any lab for that matter, any lab machine, it only shows bilirubin, SGOT, SGPT, all these things, right? Urea creatinine only comes in the renal function test, right? Which means by giving money and getting the service or the equipment or whatever the item, you get the same service across the country. That is what is known as standardization. So these services, 30% of the healthcare services have been standardized, whereas remaining 70% of the healthcare services have not been standardized. Why? Because they depend on manpower. That is the reason why you have one leading doctor, another person is not a leading doctor. People go to only to leading doctors or known doctors or famous doctors. If you have a hospital, last 10 years, 15 years, you have been the gynecologist, you have been the surgeon, you have been the physician, you have been the cardiologist, you have been the nephrologist, neurologist, orthopedician, whoever it is, diabetologist, because you have proved yourself. So people come to you. Suppose if you want to set up a department, another department, let us say you want to set up, for example, a nephrology department. No, dialysis machine is easy to buy. RO water is easy to get. Dialysis is easy, but the nephrologist or the system of people you have to standardize, right? You want cardiology department. It is easy to buy. You pay money, you will get the cath lab machine. But do you get the proper team, cardiac team for that? Now, for people where you require only one doctor to set up a department, if the story is like that, if you want to set up ICU or emergency department, it's the round the clock department. Now, if you get two doctors or three doctors, how are you to be sure that the quality of care given by them can be the same? Similarly, you get a team of nurses, let us say 6 nurses, 8 nurses, 10 nurses. How are you to be sure that they deliver the same type of services? Okay, you set up the team today. Okay, after 1 year of war struggle, you could set up a team. How are you to be sure that the team will continue the same? Tomorrow, people leave the organization, then the whole entire teamwork is gone, no? So that is why, except the chains of corporate hospitals in cities, all the small and medium sized hospitals in small towns and suburb areas, when they are headed by doctors, only those departments are okay. But when it comes to setting up other departments, there is problem of standardization. There is problem of defining business models. There is problem of defining the quality delivery, systems there. There is problem of setting up policies to deliver quality and then define a business model there. So this is the reason why people struggle to grow, to set up more and more departments in the hospital. They give up. They think that, okay, it's difficult for me to get people, so I am like this. This is the main reason why we don't grow. The hospitals do not grow to the next level. Not because you don't have money. There are banks to fund us left, right, center. There are all these 30% pharma, equipment, diagnostics, and other things. Digitalization, everything you can buy. Just give money, you can buy. You take loan, give money, buy. You have people there in and around who are waiting for services to get. What is your problem? To set up and establish other departments is the problem, because they fall under this red category where they are human dependent. They need policies, protocols, and then proper supervision. And you cannot spare your time because you are already drowned as a doctor in your OPD, IP, and maybe so if you are a surgeon in surgeries, administration of the hospital, your 24 hours is gone already. So who will sit on this? So that is the main problem why small and medium-sized hospitals they face challenges to grow to the next level. If they are fortunate enough to get certain people who can set up the departments, that is when they grow. Now that is where CIPACA came out with a solution where what we do is we want to make the best critical care available to patients across hospitals of different levels by making collaborations. Simple. So, how do we make best critical care available across all the hospitals? Because we standardized it. We know how to set up and manage ICUs. We provide multidisciplinary ICU teams, both medical and paramedical. We have different levels of supervising teams, cluster and regional level teams to ensure quality of training and execution and patient care, and then policies and processes. We also support in marketing and business development of the private hospitals, ultimately providing international standards of ICU treatment for the middle class. That is how it works. So, how do you set up an ICU? There are steps in setting up an ICU. First of all, you have to give experienced ICU team, all the team, not just doctors. You see, by just bringing a doctor, it doesn't work. A doctor may be good, but he needs to be a good administrator also, no? And round the clock, he has to take care of the both the things. And he needs to be a HR. Do you think he's a HR person also to bring nurses? And then do you think he's a training person also to train nurses? And then ensuring the quality, all these works where how can one person do? So you need a system for that. So you have to give ICU team. Then you have to ensure round the clock, uninterrupted, same quality of services, not just daytime. Many hospitals they have consultant coming and making rounds and going away. And rest of the times you on call, the person may come. But who will take care of them during nights if the patient crashes? How can you get a correct ICU by that? And then get the super specialty backup team. If you have super specialists or other specialists available locally, very good. If they're not available, when you have a standardized structure here below, then you can take telemedicine opinion from them. Not making tele ICU. Suppose your entire structure is only tele ICU, then you are gone. Who will structurize? Okay, people can give opinions and then give the care related pathways to people. The problem here is not guidance. Problem here is execution. Problem in rural places is not guidance. If I sit in metro city and give guidance to doctors in the rural area, who is going to execute it? Who is going to supervise it? Now, suppose you have a team there on the spot who knows everything and who is already providing uninterrupted services. Then you can always have the specialist coming and going, giving inputs on their own departments. If I have, let us say, a patient with MI, I thrombolized the patient in the ICU. I don't need cardiologist for that. If the patient is ongoing, let us say chest pain, and then if the cardiologist is not available directly, I contact him on tele, and then if he says that yes, this needs, let us say, cath, then I refer the patient to or shift the patient to another place where I can take primary angioplasty. Otherwise, I don't have to refer the patient out. No. Similarly, gastro, pulmo, for that matter, I just need an opinion from the pulmonologist saying, okay, boss, let us start this antibiotic. Otherwise, all the ABG, all the acid-base balance, all the ventilation, airway breathing circulation, basic management of ICU, nutrition, if my team here can do all these things, why should I refer a patient at all? So I just need support teams, that's all. Now, once you do that, then set up the international protocols, not just inpatient care. ICU is not just a patient care. You need to have protocols. You need to have timelines, when should I, what is my needle time, door to needle time for antibiotic for that matter of fact, IV fluid resuscitation for that matter of fact. How can I ensure that there are no bed sores or the complications developing for the patient. All these things, they depend on processes and protocols. After that, there should be supervision because you give book of protocols, it's not going to happen, no? You have to ensure that all these people follow these things. If somebody is not following, you have to remove that person or correct the person. So that supervision is what is required. When you ensure all these things, then you become a center of excellence in ICU. It's a process. To begin with, you start with this. Over a period of 2 to 3 years' time, you reach here. That is when hospital will become a center of excellence. From being a referring hospital, how can it become a referral hospital for others? This is how it becomes. Once you become this, even the super specialty departments, they come to us saying, yes, I have no problem right now to keep my patients. And people will come to us. So this is the foundation for growth. So how do we standardize? You standardize, first of all, the infrastructure. I should have, if I am putting 5-bedded ICU, what is my list? If I am putting 10-bedded ICU, what is my list? Across all hospitals, I need these things. What are my teams? How am I going to engage people here? What are their qualifications? What are their experience levels? How am I going to take them? Who do I need in the first year? And then after third year, who do I need? Based on the number of patients, I should have processes defined and then administration process. How am I going to manage each one of the patient? And then, yes, not just documentation, but the working model has to be standardized. And how am I going to do marketing or branding or business development for my rural area in that place? When you have everything standardized, that will become a model. And that model, when implemented properly, will succeed. You see, when you take metro cities where you have big mega hospital brands, each ICU normally, don't you think they cost at least 50 to 60,000 a day? And including pharma, lab, and other things, if the patient is on CRRT, so other organ supports, it touches almost a lakh a day, isn't it? Similarly, you go to the second level cities where, something like Pune, or Coimbatore in Tamil Nadu, or Vijayawada in Andhra Pradesh, something like that, where the second level hospitals, they are also metro hospitals, but they charge approximately 25 to 30,000 a day normally, and total bill will become 50 to 60,000 a day. And whereas some of our hospitals, for example, where we are in collaboration with CIPACA in rural areas, in taluk areas, we charge 5 to 10,000 a day. So the total cost will not be 10 to 25, 20,000 a day, which is 25% of the big corporate hospitals, and sometimes it is 10% of the metropolitan top class hospitals. So the people, the patients need not travel to such an extent to get these services. You are actually making it accessible and also affordable. For example, what are the patients that you can manage when you have a multidisciplinary ICU? All the patients. When they have problems, you can manage them. Only, probably, I would like to give you a few examples. Let us say you don't have a neurosurgeon, there is a midline shift after trauma. Maybe that time you may have to transport faster. You have thrombolized the patient, but there is ongoing ischemia. You need primary, PCI. Maybe you have to transport at that level. You have a polytrauma where you need several surgeons, ortho department, plastic surgery department, cardiac department, gastroenterology department. There is liver laceration, there is lung contusion, there is, head injury. You need neurosurgeon. Then yes, maybe that's not the place where you can manage, in a rural area, in a taluk hospital ICU, where there is a vessel cut, for example, artery cut. You need a vascular surgeon. You don't have. So except the surgical emergencies, okay, or procedural emergencies. Rest all the 95% of the patients you can manage. Cardiothoracic surgery, 95% of the times it is an elective surgery. So you stabilize and then you can, even if you think you need CABG, CABG is not an emergency, at least most of the times. So all the other problems like diabetology, endocrinology, ENT problems, gastro problems, surgical problems, medical problems, obs-gynec problems, oncology problems, they are all medical problems most of the times. If I have a general surgeon available in my place to take care of basic surgical procedures and a general physician at least on call, my ICU is enough. Okay, if I don't have a general surgeon, I don't take surgical problems where I need surgical, complicated surgical procedures. Otherwise, all the other patients can be managed in an ICU. No, 90 to 95% of the medical problems and at least 60 to 80% of the surgical problems can be managed in a multidisciplinary ICU, at least to stabilize. Then you either call the surgeon here or send the patient there. Many times after the second and third year, in our ICUs, we have surgeons coming into our place to perform the elective procedures and non-emergency procedures.